My name is John Pandolfina. I'm the president of the ANMS, and I'd like to welcome you to the ANMS Better Together, Bridging the Divide Between Pediatrics and Adult GI Motility Disorders. This is our virtual webinar on anorectal manometry, when, why, and how. Now, before I start, I just want to remind everyone that we will be having an in-person meeting in Boston in August, and we're really extremely excited about seeing everybody, and I hope you can make it. Now, I'd like to introduce our moderator so we can get started on this particular webinar. Leonel Rodriguez is the Chief of Pediatric Gastroenterology, Hepatology, and Nutrition and Director of Neurogastroenterology and Motility at Yale University. He has an interest in clinical and translational research in neurogastroenterology and motility, specifically colonic and anorectal function. Leonel, take it away.
Thank you, John, for the introduction, and to the NMS for the invitation to participate on this webinar. Welcome, everybody, to our session today, Anorectal Manometry, when, why, and how. My name is Leonel Rodriguez. I'm a pediatric gastroenterologist at Yale University, and I'm honored to be your moderator today. Our agenda today includes two presentations covering the most important aspects related to the indications, the performance, and the utility of the anorectal manometry in clinical practice, while at the same time emphasizing the differences and similarities between adult and pediatric patients. Our speakers will follow their presentations with case scenarios that will highlight the clinical utility of the test, and at the end, we'll reserve some time for questions. It is a great pleasure to introduce our first speaker, Dr. Lusine Ambartsumyan, a former fellow and a great friend and colleague. She's an associate professor of pediatrics at the University of Washington and the director of the gastrointestinal motility program at Seattle Children's Hospital. Her primary clinical and research interests include the mechanisms of fecal incontinence and continence in children with functional and organic defecation disorders, especially children with anorectal malformations, neurogenic bowel, and post-surgical Hirschsprung's disease. She will provide an introduction to anorectal manometry and will expand on the particular aspects related to children. Lusine.
Thank you, Dr. Rodriguez, for this wonderful introduction. And thank you, ANMS, for this gracious invitation. I'm very honored to be here today. Today, we will talk about the anorectal manometry, the when, why, and how in pediatrics. Our objectives are to review the indications for anorectal manometry in children, to discuss the interpretation of anorectal manometric findings and its limitations as it pertains to children, to illustrate the clinical utility of anorectal manometry and its impact on the evaluation and management of pediatric defecation disorders. Indications of pediatric anorectal manometry are to evaluate defecation dynamics in patients with chronic constipation, to evaluate for the presence and quality of the rectoanal inhibitory reflex, to assess rectal sensation and sphincter tone in patients with fecal incontinence associated with neurogenic etiology, and to evaluate patients with Hirschsprung's disease and anorectal malformations who have persistent defecation problems after surgical repair. The following table compares conventional, high-resolution, and high-definition manometry. Catheter characteristics, capabilities, and costs vary between the type of catheters and the specific manufacturer. Advantages of conventional manometry include low cost, excellent durability, and ease of maintenance. Disadvantages include fewer sensors at wider intervals. It is technically more difficult to use these types of catheters in pediatrics, and it is more challenging to interpret due to white noise and a specific overlay. With regards to high resolution catheters, these offer much more greater advantages, and these include greater number of sensors at close intervals, longitudinal and circumferential sensors, a color contour plot, and ease of use and interpretation. However, there are lack of normal values in pediatrics. There's differences in technique and protocol. They are more fragile and less durable, and they are very expensive. High-definition anorectal manometry offers 256 sensors that are distributed radially and longitudinally. It characterizes the anal canal and offers possible anatomic correlate of muscle function. However, it's very rigid and it doesn't conform to the anorectal angle. It may be uncomfortable for some of our patients, especially in pediatrics, and the large diameter may lead to falsely elevated intraanal pressures, especially in young children. Preparation for anorectal manometry is very little. There is no need to stop the medications prior to the study. Usually our patients get bowel preparation, either an enema or a suppository the night prior or the morning of the anorectal manometry. However, unlike adults, sedation may be required for select children who may not cooperate during the study. The selection of sedation or the anesthetic is very critical because the specific anesthetic or the sedative may affect the rectoanal inhibitory reflex. It could also lower the resting anal pressures and therefore making it very difficult to assess the rectoanal inhibitory reflex. In 2017, ANMS and NASPGHAN released a joint consensus document on anorectal and colonic manometry in children. Anorectal manometry is used to evaluate the voluntary and the involuntary properties of the anorectum. Within this protocol, they highlighted the very important parameters that are necessary in pediatric anorectal manometry. And these are to first obtain the length of the anal canal, subsequently the resting anal pressure, followed by the rectoanal inhibitory reflex, then rectal sensation, including transient rectal sensation and critical volume, squeeze, and the bear down maneuver. Balloon expulsion testing is offered in limited motility centers in pediatrics. However, it is not commonly performed in pediatrics, and there are no set protocols for this test. The one thing that sets apart pediatric from adult anorectal manometry is that in most pediatric centers, it's the motility specialist who performs the manometric testing. In addition, successful completion of the test really depends on the age of the patient, the development for the patient, as we have many patients who have developmental delays, the medical and psychological comorbidities, and also really depends on patient cooperation. Yates et al. In 2021 conducted a systematic review of 227 pediatric anorectal manometry studies. They were able to display significant variability in the indications for anorectal manometry in pediatrics, the ARM parameters utilized, and also the sedation and the anesthesia used, as depicted in the table on your screen. There's significant heterogeneity in the type of equipment, methodology, and protocol between the studies and their centers. Therefore, this leads to lack of normal, validated, and reproducible values in children. So given these above-mentioned limitations in pediatrics, how does anorectal manometry change the management of pediatric defecation disorders? The two parameters that play a very critical role in our medical decision-making include the resting anal pressure and the rectoanal inhibitory reflex. We will discuss these in more detail. In pediatrics, the absence of the rectoanal inhibitory reflex warrants further investigation. It is important to first exclude equipment error and operator-dependent error. Once these are excluded, then we classically know that rare is classically absent in patients with Hirschsprung's disease, in those with internal anal sphincter achalasia, in patients who have had circular rectal myomectomy, and patients who've had complex anorectal malformation repairs. In addition, those who have megarectum may also have an absent rare, as not enough balloon volume was used to generate the rectoanal inhibitory reflex. Therefore, when a patient does not have a rectoanal inhibitory reflex, a full thickness biopsy is the next step to rule out Hirschsprung's disease. If it is confirmed that the patient has Hirschsprung's disease, then they will undergo the necessary pull-through, the surgical procedure. If they have a normal biopsy, then the next step is to optimize their stimulant medications, and if necessary, to do internal anal sphincter Botox, but all of that would significantly depend on the patient, their clinical history, and their response to medical treatment. Well, how about if the anorectal manometry shows a normal rare, but we find abnormal rare characteristics? In figure A, you can see the rectoanal inhibitory reflex following a 10 ml balloon inflation. However, what you can notice through the vertical and the horizontal lines is that the rectoanal inhibitory reflex, that it has increased percentage of the internal anal sphincter relaxation, and also there's prolonged internal anal sphincter relaxation. In figure B, you can see a sustained balloon inflation where you would expect the rectoanal inhibitory reflex. However, during this 1 minute sustained inflation, there is no recovery of the internal anal sphincter. It only recovers after the balloon is deflated. So this is an abnormal internal anal sphincter recovery. And when we see these findings, these are indicative of neuropathy of possible neurospinal origin. In the following study, the anorectal manometry recordings of 7 patients with isolated sacral agenesis were compared with healthy controls. Figure A and B represent the anorectal manometry findings with percent internal anal sphincter relaxation with serial balloon distensions in figure A and duration of relaxation in figure B. Patients with isolated sacral agenesis were found to have prolonged RARE and more pronounced RARE with a left shift in the dose response curve. In the following study, anorectal manometries of 10 children with constipation who had abnormal MRI were compared to 10 age-matched children with normal MRI. Figures A through D represent conventional anorectal manometry tracings. Figure A shows a normal ARM with a clear dose response curve. Figure B represents an ARM tracing from a patient with a tethered cord. Here you can see that smaller balloon inflations cause a greater percentage of RARE and more pronounced RARE, therefore a left shift in the dose response curve. Figures C and D show intraanal spasms with serial and sustained balloon inflations respectively. The presence of the anal spasms during anorectal manometry was predictive of a spinal anomaly in 60% of the cohort in this study. Therefore, when a patient has increased IS relaxation, prolonged IS relaxation, abnormal recovery, low intraanal pressures, and/or spasms, we recommend an MRI of the lumbosacral spine. And if it's abnormal, displaying any signs of tethered cord, such as the conus being low-lying or a lipoma, the patient is referred to neurosurgery. In summary, standardized methodology and protocol are necessary to establish normative and validated values in children. Methodical use of anorectal manometry in the appropriate clinical setting can hold significant clinical utility and change the management in pediatric defecation disorders. Thank you.
Thank you, Dr. Ambartsumyan, for your excellent presentation. And to complement this great presentation, it is my pleasure to introduce Dr. Patricia Garcia. She's the director of the GI Motility Lab at Stanford University. She's also part of the Stanford Pelvic Health Center, which is a multidisciplinary center treating patients with complex pelvic disorders. She will discuss about the most important aspects of the anorectal manometry in adults and the new advances in the standardization and clinical utility of the test. Patty.
Thanks so much. Let me just start sharing my screen. Okay, so thank you again to the ANMS and to my co-presenters for giving me the opportunity to, to talk about anorectal manometry. When I started thinking about this topic, I immediately thought about using the London classification to frame the when, why, and how of ARM. And while I suspect that some of you are familiar with this classification, some may not be. As we all know, anorectal dysfunction affects between 1% to 5% of the population, and anorectal manometry in combination with rectal sensory testing and balloon expulsion are the best established investigations of anorectal sensory motor function. That said, variations in hardware, software, protocol, and interpretation really impact our ability to do collaborative research and ultimately to provide consistent clinical care. In an effort to start the standardization process, the International Anorectal Physiology Working Group was established. It's a collaborative of 29 gastroenterologists, coloproctologists, and physiologists from 12 different countries who spent many years working to establish 3 things: a consensus protocol for anorectal manometry rectal sensation testing and balloon expulsion, metrics for describing anorectal function, and a classification schema using those metrics to interpret that protocol. Their recommendations were actually published in 2019, but they were officially presented in the Journal of Neurogastro in 2020. It seems to me that with COVID dominating 2020, maybe that we have yet to fully rally around the new protocol and the new classification scheme in the way that we have around Chicago. So I'd like to take the next few minutes to go through the highlights. So let's start with the why of anorectal manometry, which I'll interpret to mean study indications. Listed here are the consensus indications from the IAPWG. So you have assessment of constipation, incontinence, and pain, as well as preoperative assessment prior to things that might affect continence, like fistulotomies or sphincterotomies, or the ability to defecate, like rectopexies, and then post-obstetric injury or trauma. There was mention of using anorectal manometry as a tool for biofeedback, with the caveat that that needed further clarification and development beyond the scope of the current guidelines. In terms of when, anorectal manometry should be performed in patients who are referred to us because they have elusive symptoms and organic pathology has been ruled out. I'll also add my additional criteria that ideally anorectal manometry should be done when it's going to change or guide our management. There was a great article from 2017 entitled "High Resolution Anorectal Manometry, an Expensive Hobby or Worth Every Penny." And the article goes through a number of advances that came with the development of high resolution anorectal manometry. Things like improved assessment of the anorectal pressure profile, decreased procedure time, decreased movement artifact, all things that we saw with high resolution esophageal manometry. That said, it also acknowledges that manometric findings don't reliably distinguish clinically relevant pathology from normal function. And a good example of this is the high number of individuals with a dyssynergic pattern on manometry who don't report constipation. Similarly, it acknowledges the criticism that anorectal manometry findings don't change management. And the classic example here is that many patients with both difficult to treat constipation and incontinence end up in pelvic floor PT, regardless of the outcome of the manometry. All that is to say, while we may not be there yet, the ultimate goal is for anorectal manometry to help us diagnose and manage pelvic floor disorders. I'd argue that coming together around a consistent protocol and a set of normative values is the first step towards that goal. So let's turn to the how, starting with the protocol. So for the sake of time, I'm not going to get into the details of preparation, positioning, catheter position, but those details are addressed in the article. What I'd like to focus on is the protocol itself, especially the maneuver durations and the recovery intervals between maneuvers. So the protocol begins with a 3-minute stabilization period to allow anal tone to return to baseline before proceeding with the resting measurement, which should be 60 seconds. This is then followed by 3 short 5-second squeezes and a 30-second recovery period between each squeeze, and then finish with a 30-second long endurance squeeze. After that, there should be a 60-second recovery period, followed by 2 cough maneuvers and 3 15-second pushes, with 30-second recovery periods between each cough and each push. Of note, for the squeezes and for the pushes, the best three attempts is used for the analysis. So the study concludes with rectal sensory testing, which can be either continuous, which is ramp, or phasic, and finally assessment of the rare. Balloon expulsion testing should be performed immediately before or after this protocol. While the article doesn't really get into the justification for these durations, and they clearly state that most of their recommendations are based on expert consensus as opposed to clinical evidence, I'd argue that in some ways it doesn't matter. While there's data about muscle fatigability and recovery justifying 30 seconds or 60 seconds, and there's data looking at the clinical difference and relevance of a short 5-second squeeze or a long 30-second squeeze, which actually is shown to be the most discriminant parameter for constipation versus incontinence. At this point, consistency is what matters most. Our current Tower of Babel situation really holds us back, not only from a research perspective, but from a clinical care perspective. I'll also note that according to this guideline, the protocol, including the manometry, the rectal sensory testing, and the balloon expulsion, is expected to take between 15 to 20 minutes. Now, how that translates across institutions remains to be seen. I'll say that at Stanford, we're just beginning to transition to this protocol, so I guess we'll find out soon enough. So now let's talk about interpretation. For the sake of time, I'm not going to talk too much about competing and corresponding classifications like Rome or dyssynergia subtypes or high anal, low rectal phenotypes. I'll just say that the London classification divides interpretation into 4 anorectal functions assessed during manometry: the rectoanal inhibitory reflex, anal sphincter tone and contractility, rectoanal coordination, and rectal sensory function. Notably, the current iteration doesn't give specific normal values. Not only is there too much variability in equipment, protocol, and practice, but there's no normative data for this specific protocol because it's so new. So the advice for now is that we keep using what we're using based either on prior publications or local data until better normative data is available. So now let's look at each part of the classification. So part 1 of the London classification looks at the rectoanal inhibitory reflex. And this is the first of 4 color-coded diagrams. So the left pink column header is the part of the anorectal manometry protocol that's being evaluated. So here it's the rare. The blue column headers on the right divide the diagnoses into major, minor, and inconclusive, with major findings not seen in controls and likely representing pathophysiology with symptoms, minor findings representing possible pathology but also being found in controls, and inconclusive findings where the clinical relevance has yet to be determined. Interestingly, this model was, these diagrams were based on the Chicago classification, which actually eliminated those distinctions of major, minor, and inconclusive in the version that was just published in January. So inside the diagram itself, white boxes here represent manometric findings and decision points, yellow boxes represent diagnoses, and pink boxes represent normal. So here you're looking at the rare, and there's only one decision point. If it's elicited, it's normal. If it's absent, the diagnosis is rectoanal areflexia, which is a major finding. Part 2 is disorders of anal tone and contractility, which looks at the rest and squeeze maneuvers from the protocol. The first branch point is whether the resting pressure is elevated. If so, the diagnosis is anal hypertension, which is classified as a minor finding. If the resting pressure is low, that leads you to a branch point which asks about squeeze pressure. A low resting pressure with a weak squeeze gives you combined anal hypotension and hypocontractility. A low resting pressure with a normal squeeze gives you anal hypotension with normal contractility. If the resting pressure is normal, again, you look at the squeeze. If the squeeze is low, then you get anal normotension with hypocontractility, and otherwise it's normal. Part 3 of the London classification looks at balloon expulsion testing and push maneuvers. If the balloon expulsion testing is abnormal, then you end up with 2 branch points, one looking for increased rectal pressure during push, and the second looking for decreased anal pressure during push. The results of these branch points give you abnormal expulsion with normal manometric pattern of rectoanal coordination, which is an inconclusive finding, abnormal expulsion with dysynergia, abnormal expulsion with poor propulsion, and abnormal expulsion with poor propulsion and dysynergia. And these are all minor findings. If the balloon expulsion testing is normal and there's any abnormality in propulsion or relaxation, then you get the diagnosis of normal expulsion with abnormal manometric pattern of rectoanal coordination, which is an inconclusive finding. Last but not least, part 4 of the London classification is disorders of rectal sensation. So this is looking at the rectal sensory test and specifically at the volumes obtained for first constant sensation, desire to defecate, and maximum tolerated volume. If 2 or more of the 3 sensory parameters are greater than the upper limit of normal, you get rectal hyposensitivity. If one of the 3 parameters is greater than the upper limit of normal, you get borderline rectal hyposensitivity, which is an inconclusive finding. If one or more of the parameters are less than the lower limit of normal, you get rectal hypersensitivity. Of note, they do mention that abnormal results may need to be clarified using a barostat. And I think this is important because for years, many of us have been reluctant to use the terms hypo or hypersensitivity when referring to anorectal manometry, because of course, manometry doesn't tell us about compliance or anatomy or mucosa. So a patient who's deemed to be hyposensitive may actually have something like megarectum. Or on the flip side, someone with hypersensitivity may have proctitis or prolapse. So as far as take-home messages, as we know from esophageal manometry, development of a standard protocol and validated classification system has made esophageal manometry an indispensable tool in the diagnosis and management of esophageal motility disorders. And there's an opportunity now for anorectal manometry to catch up. Even if this iteration of the London classification protocol aren't perfect, now's the time to come together, use it, refine it, and perfect it. It'll only be successful if our motility community embraces it and helps push it forward. So let's make London the next Chicago.
Thank you, Dr. Garcia, for this complete presentation and then delineation of the London classification. We will proceed now to present some case scenarios, and we'll have plenty of time to discuss those and then have some questions from the audience. So these are the cases. This is the first case. Dr. Ambartsumyan.
Thank you, Dr. Rodriguez. This is a 6-year-old female who presents with fecal incontinence. She had constipation at age 4 that has progressed over the past 2 years to fecal and urinary incontinence. She has failed osmotic and stimulant laxatives, and there's no history of weakness, numbing, of tingling of extremities. Past meconium within 24 hours, no history of fecal impactions, no family history of Hirschsprung's disease, no medications. Physical exam is otherwise reassuring. The rectal exam has a soft stool in the rectal vault. There's normal anal placement and tone. We were unable to elicit an anal wink given some patient anxiety. The spine had no midline defects, no gluteal deviation, and otherwise a normal neurological exam. Next slide, please. The following is the anorectal manometry for our patient. Here we can see that the mean intraanal pressures were in the 30s and 40s, so somewhat low. And most importantly here you see is serial balloon inflations with 20, 30, 40, and 50. And what's very apparent here is that there's an increased percentage in rectoanal inhibitory reflex and a duration of the rare in seconds with serial inflations. And thus we have a patient who has an abnormal dose response curve with serial balloon inflations. We also did a sustained balloon inflations. And in doing sustained balloon inflations, we keep the balloon inflated for the 1 minute of the inflation. And we are looking for the intraanal sphincter pressures to recover to normal. Here we can see that on 10, 20, at 10 ml and 20 ml balloon inflations, there is recovery. There's some recovery within the 30, but when we try to do the 40, 50, and the 60, there is no recovery. Once the balloon was deflated, as it is shown with the arrows, then the intraanal pressures returned to normal. And this is abnormal, as there was no normal recovery at those volumes. Next. Given that the patient here had low intraanal pressures, abnormal rare characteristics, and failed intraanal pressure recovery with sustained balloon inflation, we recommended an MRI of the lumbosacral spine. The MRI showed that the conus was at L3 and a lipoma. This was a patient who met clinical signs and radiographic signs and manometric signs of a tethered cord. They were referred to neurosurgery and a cord detethering procedure.
That's the conclusion of the first case. We're gonna go to the second case. Dr. Garcia.
Okay, great. So the first case is of a patient I saw recently who came to see me for urgency and fecal incontinence. She was having unpredictable episodes of stool urgency and leakage several times per month. And in between episodes, she described a mixed picture of both constipation and diarrhea, with her memory being that on average, she was having a Bristol 3 to 4 daily. She takes ibuprofen for headaches, methimazole for thyroid disease, and amlodipine for her blood pressure. And she'd tried a bunch of things. She'd tried fiber and gluten-free and dairy-free. She'd tried relatively high doses of Imodium and Kegels, and none of those things had helped. In January, she'd had a colonoscopy, notable for 3 small tubular adenomas, and her recent thyroid studies were normal. Next slide. So this is her anorectal manometry. So in terms of London, for part 1, she had a normal rare, which I'm not showing. And for part 2, she had normal resting and squeeze pressures, which I'm showing here. For part 3, she had abnormal balloon expulsion and increased rectal pressure during push, which is normal, and increased anal pressure during push, which is not normal, and give her the diagnosis of abnormal expulsion with dysynergia. And finally, for part 4, her first constant sensation volume was higher than normal at 80. Her desire to defecate was normal at 100, and her maximum tolerated volume was 325, which again was higher than normal, at least in our lab. So that also gives us the diagnosis of rectal hyposensitivity. So bottom line, based on anorectal manometry, she has dyssynergia and decreased sensation. So the question I'm posing here is, what does her X-ray show? And perhaps the question itself is a bit of a giveaway, but I'll show you the X-ray. So the X-ray showed a moderate stool burden in the ascending and descending colon. And again, this is not the most dramatic full of stool X-ray there is, but if you take this together with the manometric diagnosis of dyssynergia and rectal hyposensitivity, next slide, you can see that the patient's symptoms are probably from a combination of constipation, overflow diarrhea and urgency, and pelvic floor dysfunction. So I started her on Linzess and I referred her to pelvic floor PT, and at our most recent follow-up, she was doing much better. And the point I'm making here is to show an example of when anorectal manometry really can change management. In a patient with chronic fecal leakage due to poor sphincter relaxation, if you treat them with Imodium or Kegels, stool retention is actually probably going to get worse. And so diagnosing dyssynergia and overflow sets patients on the right treatment path.
Thank you, Dr. Garcia. We're going to the next case. Dr. Ambartsumyan.
Apologies. Thank you, Dr. Rodriguez. Our next case is of an 8-year-old male who presented to our office with constipation. This was a referral from a GI doctor in our same institution. This child has had constipation since toddlerhood. He used to have 1 bowel movement per week and has daily fecal smearing and significant withholding described by the parents. He has failed osmotic and stimulant laxatives as up to Senna dosages of 40, 50, and 60 milligrams. Again, he denied weakness, numbness, and tingling. Of note here is also that he was significantly being bullied at school and was beaten up by his classmates because he was smelling of urine and of stool. He did pass meconium at 24 hours of life, and he also has autism and ADHD, further complicating his medical history and the psychosocial effects of this. He's had multiple fecal disimpactions, at least 1 to 2 times a month. He has no family history of Hirschsprung's disease, and he lives with his parents and is the only child. It has progressed so bad that the parents are now considering taking him out of school and doing homeschooling. His medication is Ritalin, and while previously he had poor growth, with changing in the dosage of the Ritalin, he's had normalized in his growth. In clinic, we're unable to do a digital rectal exam due to anxiety. Just approaching him or touching him is very difficult. With the help of the parents, we're able to look at the perianal area, and there's significant stool smearing and stool on his underwear. And we're unable to elicit, of course, an anal wink as he refuses us to touch him. There's no midline defects of the spine, there's no gluteal deviations, and otherwise, based on our limited neurological exam, it was reassuring. Next slide, please. When he was referred, he had already had an MRI of the spine, as depicted in your right-hand side. Because he had urinary incontinence and stooling incontinence, the primary GI person who referred him, they decided to get an MRI of the spine, which was great because he did not have a lipoma and his conus terminated at L1. But what was very concerning, as depicted in the picture here, is the very large diameter of the rectum and also significant diameter of his colon. We had done a SITS marker study for him as well. And here in the abdominal X-ray, you can see the significant large diameter of stool that is present, the colonic dilation, and the retention of the SITS markers. They're not only retained in the rectum, but they are evenly distributed, one would say here, through the sigmoid and the descending colon. And there is significant colonic dilation for this patient. It had become so bad that he was having trouble actually ambulating at home and would become in so much pain, and that would then necessitate him to be presenting to the emergency room, where then he would undergo general anesthesia and have fecal disimpactions every few weeks. Next slide, please. We did anorectal manometry with intranasal Versed. We know that the Versed will calm his anxiety, but it will not alter our rectoanal inhibitory reflex characteristics and will not lower our intraanal pressures. And that is why we had picked Versed. He had elevated intraanal pressures in the ranges of 110 to 120. He had an absent rectoanal inhibitory reflex, but this was very difficult to truly assess because he was not fully asleep and he did have withholding. So with every balloon inflation, he would squeeze and we would have an increase in our intraanal pressures. And in pediatrics, when we personally do the test ourselves, we do have our finger right by the external sphincter. So when he does squeeze, I can also feel that he's squeezing and his withholding, and we can look at the legs and we directly observe the patient as well, which is definitely an advantage for us. Next paragraph, please. In this patient, because he had an absent rectoanal inhibitory reflex, we referred him to have a full thickness biopsy. His full thickness biopsy for Hirschsprung's disease was negative. So thus we have a patient who's had a normal biopsy. And our differential here is quite complicated because this could be internal anal sphincter achalasia, which is a non-relaxing intraanal sphincter with a normal biopsy. It could be the fact that we were not able to get a rectoanal inhibitory reflex because he's withholding, which is definitely is a possibility as observed during the rectoanal inhibitory reflex. And also he has a very large rectum. And because of this, we went up to balloon volumes of 60, 120, even 180, and still unable to elicit a reflex. And also we could see the large rectum both on the MRI and on abdominal X-ray and on exam when he had received Versed. Given the progressive colonic dilation and worry for colonic decompensation, the behavior, the withholding, the significant recurrent impactions requiring anesthesia for disimpaction, and such a grave effect on his quality of life, decision was made to move forward with internal anal sphincter Botox administration. This served to be a bridge to maximize stimulant medications, pelvic floor therapy, and in him specifically, behavioral modifications within our autism center. Next slide, and I think we're...
Thank you, Dr. Ambartsumyan. And the last case, Dr. Garcia.
Okay, thanks. So this is another case I saw recently of an 80-year-old gentleman who had had a low anterior resection for a rectosigmoid carcinoma in 2019. And he was now coming to me with fecal seepage and fecal incontinence. And his most bothersome symptom was this constant passive seepage leading to really painful irritation and breakdown of his perianal skin. And he tried fiber and Imodium and Lomotil, and he was also using a lot of Desitin to try to help protect that skin and use a barrier cream, but it really wasn't working. He'd had a colonoscopy done in mid-2020, which had showed hemorrhoids and a relatively normal appearing anastomosis. Next slide. So what I'm showing here is a condensed view of the first part of his anorectal manometry, which is the resting pressure and the squeeze maneuvers. And what you can see is the resting pressure window is all the way on the left, and then the squeeze attempt is all the way on the right. And so one of the great things about high resolution pressure topography is how intuitive the visual representations are. So you can really see here that the resting pressure is low, but he absolutely can generate a lot of squeeze pressure that is sustained, which again is that area all the way to the right. So the London diagnosis here would be anal hypotension with normal contractility, which is a major finding. Next slide. So again, my goal here in these cases is to give examples of how anorectal manometry really can be worth every penny and how it's not just an expensive academic hobby. You know, in this case, the patient has normal squeeze, but impaired resting tone, which indicates profound dysfunction of the internal anal sphincter. And the thing about this is that no matter how many Kegels this gentleman does, his resting tone is essentially going to stay the same. So sending him to pelvic floor PT just prolongs his symptoms. And the best next step here is sacral nerve stimulation. And I'll take a second, even though it's not quite the scope of this talk, to say that low anterior resection syndrome is really common after rectal cancer resections. And the etiology is likely multifactorial, with sphincter injury, fibrosis affecting the compliance of the rectum, and local and maybe even more global denervation between the neorectum and the anal canal. So sacral nerve stimulation works by modulating motor and sensory nerve signaling, which is why it's an especially good choice in these kinds of cases. I'm showing a good review article here from 2019 looking at SNS for low anterior resection syndrome. And I think these are also great cases where anorectal manometry really does point you in the right direction and change management.
Thank you, Dr. Garcia. This concludes our case presentations. We're open for questions now. We're going to address as many as you can. If there is not enough time, I think we do have time. We can address those in Doc Mato. We'll give that information at the end. So the first question is, would you keep the balloon inflated for the whole minute to evaluate for the rectoanal inhibitory reflex recovery?
That is an excellent question. Thank you for bringing it up. When we evaluate for the sustained balloon inflation, yes, we keep it inflated for as long as it takes for the recovery, but usually it is for 1 minute, and we should expect full recovery within that 1 minute.
Excellent. Thank you, Dr. Ambartsumyan. The next one is, what normal parameters do you use for resting pressure, squeeze, and rectal sensitivity? This goes both for both adult and pediatrics.
Yeah, I mean, I'm happy to start. I'll say that normative values are one of the things that are really hard to define on the adult side and probably on the pediatric side. There are several published normative values. We know that what is normal varies based on gender, based on age, based on the catheter that you're using. So the 3D catheter versus just the high res. We know that it varies based on the protocol that you're using. So there aren't a lot of good one-stop shop, everybody agrees with the normal values. In addition, the London classification, which we just discussed, doesn't really address normal values in as much as they're not saying this is what you should use. They're sort of acknowledging that we have a problem, that we need normative data, but part of that means that we need a normal protocol or a consistent protocol so that we can get normative data. And maybe that means that once we start using the London protocol, we will have normative data. Maybe that will be segregated by gender or by age, or maybe it'll just be a range where everybody's encompassed. But for now, it's a little bit all over the board.
Thank you, Dr. Garcia. I would have to say I echo what she says with regards to pediatrics, except it's much worse in pediatrics. We definitely do not have any normative data. And when we do have some normative data, usually it's a retrospective study, those studies are not validated. And they are using different types of equipment, water perfused, or they're using different types of high resolution catheters, and it could be 3D catheters, but it has been very difficult. And so thus, none of our data is based on normal values. And even the normal values are based on patients with constipation or incontinence. So thus, we are left in a little bit of a bind with pediatrics.
Yeah, just to complement that from Dr. Ambartsumyan, you're right. I mean, it's very difficult in pediatrics because we don't have normal values pretty much for anything. It's very similar to any invasive testing that we do. For the longest, we've used values based on a study came from the Netherlands that established that the resting pressures were between 30 for the lowest to like around 100 for the highest. And that's the standards that we use. There is 2-3 more studies that came in the last few years using very different parameters, very different methodologies, plus different types of equipments, which makes it difficult to try to standardize. So we do use that for resting pressure. It's a little bit more complicated for rectal sensitivity and for squeeze. The next question is London classification applicable to pediatrics?
From our perspective, at this time, I don't believe the London classification is applicable to pediatrics. In the London classification, specifically the concentration is mainly on sensation and push and bear down. And in pediatrics, it's so difficult to get the children to do anything. And our primary goal is mainly the rectoanal inhibitory reflex, and it's more of its characteristics. In older children who can cooperate, we can get the cough reflex and we can get the sensation and we can get the push. But I would say that it is significantly harder, even in our teenagers, to be able to have them follow direction. And the protocols we have, and we don't even have any protocols in place as to how to do them. So I would say that 90% of the motility specialists and the motility centers all do different types of protocols and different ways of doing it. So thus in pediatrics, that would be what we would strive for. It would be best if we could combine all of our efforts and do studies together to get to a London classification, but that's going to take a lot of effort. And we are in the process of doing such studies and such collaboration, but it is critical.
Yeah, we have tried to standardize how the test is performed and how the test is interpreted, but an easy way to answer would be the same way that we will answer when the Chicago classification came out and said, like, is it applicable to pediatrics? Well, if you do certain adjustments based on age, size, possibly, but until we have data, it's difficult to make it applicable to pediatrics the same way that is used in adults. The next question is, do you usually get a full thickness biopsy, not start with suction biopsy?
So that is an excellent question, and it has been up for a little bit of debate, depending on the institution. So usually in most institutions greater than age 1, surgeons prefer to get a full thickness biopsy. One, because the child is too squirmy and it's going to be very difficult to get rectal suction biopsies at 1, 2, and 3 centimeters above the dentate line. And a full thickness biopsy will actually give you the exact, the submucosa as well for you to look at the ganglion cells. In our institution, we get full thickness biopsies in those greater than 6 months of age because of our own internal QI efforts and our studies and that we have shown that we have greater ability to not have inconclusive studies if we get it above 6 months of age. So yes, in patients in general above a year old, a full thickness biopsy would be recommended versus a rectal suction biopsy. Ultimately, a biopsy is recommended to make the diagnosis of Hirschsprung's disease.
The next question is, I think it's primarily for Dr. Garcia. It's in terms of like the best techniques and equipments to do biofeedback in adults and equipments. I don't think that we have to talk about equipments, but.
Yeah, so I'll say that we're really lucky at Stanford because we have a wonderful group of pelvic floor physical therapists. And, I think a lot about what makes the best biofeedback is what you have available, because I practice in a lot of different places. And sometimes it's really hard to get patients, a physical therapist or a nurse or anybody who does biofeedback. And I think the best biofeedback is the biofeedback that you can get. I will say though that my one plug is maybe to say that I think biofeedback is important though. So I send a lot of patients for pelvic floor PT who live maybe hours away and they're not going to come to Stanford to our public health center, and they end up seeing pelvic floor PT and they don't get any biofeedback. And I think that that really isn't the best, especially when you're dealing with things like dyssynergia. So I don't think that there's a right biofeedback. I also will say that some people use anorectal manometry catheters to do biofeedback. Some people actually use abdominal ultrasound to do biofeedback. And again, so long as the person who's doing it is an expert, I think any of the methods can be effective.
The next question is, what sedative do you use during ARM in anxious pediatrics patients?
The most common sedative, we use either IV Versed, PO Versed, or intranasal Versed. That one is the most efficacious one. It does not affect the rectoanal inhibitory reflex characteristics, and it does not affect the intraanal pressures. And it calms the patient down, and and you're able to administer it in all of those 3 forms.
Great. The next one, for Dr. Garcia, are you performing the balloon expulsion test sitting on a toilet or lying on the left lateral position?
So we definitely do balloon expulsion sitting on a toilet. So we have a private bathroom connected to where the anorectal manometry procedure room is. And then we do use a Foley. And then they're sort of, the balloon is inflated while they're there, and then they're kind of walked to the restroom, and then they're asked to do the balloon expulsion. I will say that we're also still doing first balloon expulsion with no assistance. And then if they can't expel the balloon, we'll use a squatting stool to see if that improves expulsion. And again, this is sort of one of those good examples of how there's a lot of variability in protocol. We like it because we think if they can improve with a squatting stool, that already gives us a therapeutic avenue. If it improves, then we say try this. It also may suggest that they'll benefit from pelvic floor PT, but it's not part of the London classification.
Thank you. The next one is, how reliable is the diagnosis of dyssynergia in kids given the issues you discussed in performing the ARM in children?
Thank you for that question. The diagnosis of dyssynergia is not reliable in children because first, they're too young to understand how to do the procedure, and they're very embarrassed, and they're laying on their left lateral side. And the adult studies show that even in adults, it's very unreliable, and yet to be reliable in pediatrics makes it much more difficult. So therefore, we do the test, but we do, use the information with a grain of salt. And we do send patients to pelvic floor therapy, but of course, our success rates with biofeedback do not compare at all to adults. And pelvic floor therapy has more recently been used in pediatrics. There's about 2 or 3 studies that support its use, and that has been the newer technique, newer modality that we are using to see if this has been helping our patients. But the test itself is not the best in terms of diagnosis for them.
Correct. And the easy way to answer that will be, do you trust the patient when he's telling you that he's not withholding when they're actually withholding? So would you trust that they're actually doing the test appropriately when you ask them to do the test appropriately? So the short answer is age dependent. I'm okay doing the part of the test evaluating for dyssynergia age appropriate, 10, 12 and above. But in a 3-year-old that has dyssynergia, I don't think that there is enough evidence to do that. And the same goes for biofeedback. If it's well indicated, there is evidence that works, but the routine use of biofeedback for functional constipation is not validated. For case 1, you could not elicit an anal wing due to issues with patient cooperation. If truly negative, likely there is a spinal correlation that you will pick up on MRI. In this case, why did you choose ARM first before MRI of the lumbar spine?
That is a very good question. Yes, our suspicion for possible neurological cause was there, but again, there could also be Hirschsprung's disease as well. So with anorectal manometry, we could evaluate for the rectal inhibitory reflex and rule out Hirschsprung's disease and rule out internal anal sphincter achalasia and evaluate for the neuropathy. And sometimes in some of our patients, they're so anxious that they have to be under sedation or even under anesthesia for the MRI. And anorectal manometry is a bit of a cheaper way and more effective way to get the most out of the information, out from one test. But yes,
you can use it as a screening test.
Yes. But
especially because there is about 10-15% of the patients that will have an abnormal MRI without any neurological deficit. So you can pick up those before they have any neurological symptom. Next question is for Dr. Garcia. What is the next necessary step and approach to improve London classification?
I think probably the next step is for the motility community to rally around it and use it so that we can get more feedback. Normative data is definitely, but also just feedback. When I was showing the boxes, there's still a lot of things that come into this inconclusive category. We need to really understand, what is the meaning of these patterns? Do they correlate with disease? Do they correlate with response to treatment? But we have to really rally around something to get consistency so we can get enough data and experience to move it to London 2 and London 3. I think aside from just using it, I think collecting normative data really, really matters, because as I see the questions here, everybody wants to know, well, what's the cutoff? What's the threshold, right? Like what's the IRP, with Chicago, right? Where do we draw these lines so we can really say this is abnormal and this isn't? And right now, the spread for some things is, 30 millimeters of mercury to 100 millimeters of mercury. That's a very wide range to say that something is or isn't normal. So we really have to figure out what we're going to say about normative values.
The next one is, please comment on how to evaluate the rare. ANMS NASPGHAN protocol uses pressure change more than 5 millimeters of mercury, but London classification says rare is qualitative.
In the pediatrics, we use greater than 5 millimeters per mercury, but in reality, when we do evaluate for the rare, it's very important to initially make sure that there is no operator-dependent error, so you are holding it in the correct place. And when you do inflate the balloon, your catheter does not come out and cause a false rectoanal inhibitory reflex. And what we are looking for is at least 5 millimeter drop in intraanal pressures and a recovery. As well. And based on the actual pattern and the velocity of the drop is then how we would determine if there is a rectoanal inhibitory reflex.
And do you do a barium enema first before doing an ARM?
We do not do barium enema first before an ARM.
I believe that if we have the capacity to do the ARM, it will help you understand more. If this is a non-relaxing sphincter, you do the rectal biopsy to then classify the patient properly. The barium enema most likely will help the surgeon if this to plan the surgery, to see where the transition, to see what type of approach they're going to use, abdominal, if they do transanal, But I don't think that it helps us, the pediatricians, as much as it does for them. Balloon expulsion test with air or water in the Foley, and how much volume?
With water, and then starting with 30. At least that's what London says, to start with 30. With the clear guidance that if you do 30 cc's and you don't elicit, I got confused. Balloon expulsion, 50, and it's water.
Is the difficulty in obtaining more accurate normal measures due to lack of data in healthy population, or more so due to the variety of equipments and protocols used? I'll take this one, it's easy, both. I don't think that there is, in pediatrics, it's gonna be difficult. It's not ethical to do an invasive study. No IRB will approve a protocol like that. So we're gonna have to continue going around using the closest to normal that we can get. For Dr. Garcia, is the balloon expulsion test at the beginning or at the end of the study?
Oops. Can you guys still hear me?
Yes.
Oh, sorry. So either one. So according to London, you can do it right before you do the manometry and rectal sensory testing, or you can do it after. I'll say that at Stanford, we do it after, but either way is fine.
The next one, would you advocate for Botox injections in the anal sphincter in the setting of normal resting pressures?
Depends on the clinical scenario. If you have normal resting pressures, but let's say it's the same patient we just presented in case 2, with significant withholding, colonic dilation, fecal impactions, then yes, I would do internal anal sphincter Botox regardless of normal pressures.
About 15 years ago, we did a study where we looked at that specifically, non-relaxing sphincter, high pressure, low pressure, and the only thing we found is that the ones that had exclusively high pressure respond the same as the other ones, except that have the ones that have normal resting pressure had a little bit more prolonged incontinence. But other than that, no significant difference. When a pediatric patient is non-cooperative during the ARM, which GA agent can be used to get reliable rares?
One could use propofol, but you have to be careful that if too much propofol is given, that you have only a specific window before the intraanal pressures become very low. So what you're risking is it won't change the quality of the rare, but it will change your intraanal pressures. So the lower your intraanal pressures, the less likely you may be able to see a difference between a drop, between a baseline and a drop, to be able to identify a rare. But you can use propofol, and there have been studies that have shown this. And there have been studies that have shown that successful use of propofol in obtaining the rectoanal inhibitory reflex, and also dexamethasone also you can use. And ketamine.
The next, thoughts on doing EMG at the time of the ARM?
For me,
Yes.
I'm assuming you guys don't do. Yeah, I mean, I think that certainly I've been in places where we did EMGs at the time of anorectal manometry, and I do think that it can give you some extra information, but it also adds to the time of the procedure and also the expertise of the person who's doing the procedure. So it's kind of trying to find the balance between how much extra information are you getting, and is it worth the time and potentially the training of needing somebody else to be doing that. I'll say that currently we don't do EMGs at the time of anorectal manometry.
Do pediatric GI motility doctors ever have ARM done by the nurses and just read them later? What's your recommendation?
There are some centers where the manometry is done by nurse practitioners or physician's assistants. I'm not aware of any centers where the nursing staff, the pediatric nursing staff does them. Our general recommendations are to have the motility specialist do them themselves or have a very highly trained physician's assistant or a nurse practitioner in motility to do them.
You have to trust your staff if you're gonna do that in pediatrics, because it's not a test that you wanna, if you don't get adequate data, bring the patient back and do it again, especially if it's a pediatric patient that you have to sedate, you know. So we are very careful with that. In general, all of us that do it and actually train physicians to do it, we do it ourselves in pediatrics. We don't really advocate for doing it for the nurses or ancillary staff to do it. And do you do ARM studies in the lateral position or upright sitting? Pros and cons. It's for both.
I would say for pediatrics, we do whichever one works to get me the rectoanal inhibitory reflex, and sometimes the patients are trying to escape from us off the table. So I personally will take anything to be able to get the rare. But usually it's the left lateral position.
Yeah, I would say that the majority of people probably are still doing left lateral, although we know that upright would be ideal. The thing about upright is logistically, it's very difficult. You know, you have to have, you know, a toilet, and then you have to be able to have somebody who's holding the catheter while running the computer. And it's just much more complex, although admittedly, it's much more physiologic if it's done in the upright position. I'll say we still do it left lateral.
Yeah, in general, in pediatrics, we do it whatever way we can get it done, you know, especially with the little ones that don't cooperate. So if they're more comfortable on their back, we do it supine. If they're more comfortable on their side, we do it on the side. You know, it's luckily we don't have to do as extensive as the adults do, so we can improvise. And that was our last question. Thank you, everybody. If there are more questions, we will be happy to answer those through the Doc Matter platform. Thank you again. It's been a great pleasure. Thank you to the speakers. I think that we all learn a lot about how to perform anorectal manometry both in adult and peds. And we sincerely hope that you have enjoyed and that we keep collaborating and bridging the gap between adult and pediatrics in the future. Thank you.